again, in terms of discontinuation, since you mentioned that, there's a lot of studies going on with real-world evidence. There's a number of groups that have been evaluating what's the real-world data in trying to compare to what we've seen in clinical trials, particularly with ibrutinib, which has been longer available. As we know, clinical trial patients are more selected. They tend to have a little bit less comorbidities. They have more oversight on taking the drug and monitoring, and they tend to stick to their dosages for a more prolonged period of time, whereas the real data sometimes is not as good. So what's your opinion on that?
Right. I think it's particularly come to the fore with ibrutinib. It was also true with chemoimmunotherapy that especially single-center trials often had selected young patients, median age of 60 or so, whereas we know the median age of diagnosis for CLL is 72, and then it takes some years more to be treated. So we're looking at patients mostly in their mid to late 70s when they start to get treatment, right? But the early ibrutinib trials, I think because of the hype about the drug and the early data that it was looking so phenomenal, there were many patients on wait lists who flew from around the country to get on these trials. So even though they were 70 or 71, their comorbidity scores were extremely low. And I think that once we got ibrutinib out into non-trial populations, that's when we started to see the hypertension. We started to see the other cardiac side effects like congestive heart failure, heart block. Atrial fibrillation showed up in the randomized trial, but not in the non-randomized phase 1b/2, right? And so then the early real-world data with ibrutinib suggested there was a 40% discontinuation rate at a median of only 6 months or so, which is obviously really high. Hopefully that has improved some as docs have gotten more comfortable with the drug. For example, if people have some early cytopenias or early infection, those aren't really reasons you need to stop. Even atrial fibrillation, you don't necessarily need to stop or change if you can control it and manage it. So hopefully that's improved somewhat, but it's still the case, as I mentioned earlier, for example, in the Alliance trial, there's a 7% death rate from ibrutinib toxicity in both of the ibrutinib arms versus 1% with BR. So there's, especially in older patients, the toxicity is significant. Even the Alliance trial, I think, probably enrolled a broader range of patients than some of the early company trials, so it's moving a little bit more toward the real world data. But, this is the type of observations that have driven us more toward acalabrutinib as our preferred drug, especially in the older patients compared to the younger patients.
Yes, and, there were trials for patients who were intolerant to ibrutinib switching to acalabrutinib afterwards, early trials showing that you did not lose efficacy by changing from the one to the other, although sometimes you've seen recurrence of the same toxicity, particularly rash seems to be class dependent there, but you didn't see as much atrial fibrillation afterwards. And I had a couple of patients in my clinical experience that I changed from one to the other because of intolerance, and have been quite successful with that. So patients who have been on ibrutinib for a prolonged period of time, except for hypertension, because you see that with the acalabrutinib as well. We don't have the long-term data yet to see if that increases over time, but I will expect a similar finding with the acalabrutinib, but other side effects tend to be hampered by the switch from one drug to the other. And again, cardiovascular being the biggest concern in older patients with using a BTK inhibitor, particularly because of hypertension, atrial fibrillation. So as well, that's why I favor acalabrutinib in that patient population, given the findings that the risks seem to be lower, at least on the absolute numbers comparing trial to trial here. And in clinical experience seems to be the case as well. However, we did see a slightly higher number of atrial fibrillation in the relapse data from the ASCENT trial with the acalabrutinib than what we saw in the frontline setting with the acalabrutinib in the ELEVATE trial. And both of them had older patients involved. What are your thoughts on that?
Well, it was slightly higher, but the control arm was much higher. So
yeah.
It looked less different than the control arm to me. I think it was
Mm-hmm.
about 5% in the cal and 3.5% in the control.
Mm-hmm.
So, right. I was
Probably
more
is an older
convinced,
population, right?
right. And also, as patients get more treated, they tend to get more problems, as we know.
Mm-hmm. Mm-hmm.
Right. But so I was more convinced that there was a slight signal for atrial fibrillation in the ASCEND data than I was, or in the ELEVATE data, excuse me, than I
Mm-hmm.
was in the ASCEND data.
Because of the control arm already
Because of the
having slight.
control
Yeah.
arm, exactly.
Yeah, that makes sense. That makes sense.